The topic here is going to be anaphylaxis. This is a very high yield topic for any kind of medical licensing examination. And the reason is because not only is it common, but it's a medical emergency that's going to require that you identify it right away, that you identify the signs, and also that you can differentiate this out from some of the other forms of shock. And anaphylaxis often presents as shock, low blood pressure, and you're going to want to be able to differentiate this out from septic shock, hemorrhagic or hypovolemic shock, cardiogenic shock, etc. All right, so we will start with a vignette. A 4-year-old boy is rushed to the ED via EMS due to sudden onset wheezing and loss of consciousness. The babysitter says that the patient was fine all morning and suddenly began audibly wheezing. After calling 911, he collapsed. There is no known medical history, including asthma, so he doesn't have asthma. He arrives in the ED 20 minutes after onset of symptoms. He's semi-conscious on 100% oxygen via face mask, and venous access has been established with 340 milliliters of normal saline. Bolus commenced en route. His initial blood pressure was 70/45. He has not received any medications at this point. Present vital signs: blood pressure 85/50, heart rate 150, respirations 28, temperature 98.4, saturation 89%. He's visibly flushed, audible wheezing is appreciated, there's no rash or swelling of the lips or tongue. All right, so we have a patient who is vitally unstable. We know this based on his vital signs. Yes, his blood pressure is at an acceptable point right now. It's on the low end of normal, but it's still tenuous. 85/50 is low end of normal, and he was, when they got to him, he was low. He was 70/45. So there is something going on here as far as his blood pressure that we need to be concerned about. We're never happy when a patient is on the low end of normal and they are currently receiving fluids. We want to make sure that that his blood pressure stays in the normal range. So he is getting fluids, but we want to keep an eye on the blood pressure no matter what. And we would consider this patient to have been in shock, and so we want to know what the cause of that shock was. Now, it's pretty clear, based on the fact that he's flushed, that he's not in a hemorrhagic or hypovolemic shock, and he's really not even in a septic shock. There's only one type of shock that will give you flushing, and that is anaphylactic shock. So all the other shocks, you're going to get paleness. The patient will be pale when they come in. They'll have low blood pressure and they'll be pale. With anaphylactic shock, they'll have a low blood pressure and they'll either be normal in complexion or they'll be flushed. So we also know that there's respiratory distress here. He's got a saturation of 89%. He should be above 92, 93 or higher. So 89% certainly low, and in the setting of wheezing, we know that there's some kind of bronchoconstrictive process going on. And so you put these together, the fact that he is in shock, that he's flushed, and that he's wheezing, and we know we have anaphylaxis here. We don't know why, but we know that this is pretty clearly anaphylactic shock. And we would hope that the EMS would have recognized that, but sometimes they're in a hurry to stabilize the patient, as they should, and so they were probably more concerned with getting his blood pressure up and possibly looking to maybe do intubation rather than providing epinephrine, which we would have preferred they did. In most cases, EMS is smart enough to do that, but for the sake of our vignette, he had not received epinephrine yet. And so that would be our very next step. We want to provide epinephrine, and for children, it's the amount of epinephrine we provide is based on their weight, although usually we would do it's 0.01 milligrams per kilogram, or you can just give them 0.3 milligrams, and this is going to be given intramuscularly. Now, you can do intravenous epinephrine, but that's typically reserved for patients that have a profoundly low blood pressure. And in that case, we're not only providing the epinephrine to help with the respiratory distress, but the epinephrine will also have the added benefit of increasing their blood pressure. So we give the epinephrine, and within 10 minutes, the wheezing is markedly improved. He's satting better. He's 95%. And then we do further questioning, and we find out that the child had ate a homemade cookie when he arrived at the babysitter's house, which was approximately an hour before the onset of symptoms. So again, very classic uh, anaphylaxis here. Homemade cookie probably has cross-contamination, nuts in it maybe, and so that can cause anaphylaxis. This child, of course, you're going to want to make sure that, well, you're going to be observing him, you're going to be providing antihistamines and steroids, and then he's going to need to follow up with primary and probably with an allergist to eliminate possible causes and look for possible causes of the anaphylaxis, so that this can be avoided in the future. You'll also want to send him home with an EpiPen as well as antihistamines, oral antihistamines, and oral prednisone. All right, so we'll talk about the epidemiology very briefly. We'll talk about the pathogenesis. This is just your typical IgE-mediated response. So we don't have to go into that in too great of detail. I did talk about IgE-mediated allergy and a lot of the other sections. Clinical manifestations, there are a lot, although typically it's going to be your cutaneous and respiratory manifestations that predominate with anaphylaxis. We'll talk about how we diagnose this. It's clinical. Management, complications, and prognosis. So the epidemiology of anaphylaxis, really, we don't know the exact incidence. And the reason is because what is anaphylaxis? So is anaphylaxis just getting hives? Well, yes, that is kind of anaphylaxis. But at what point is it no longer just an allergic reaction? What point does it become anaphylaxis? And really, anaphylaxis is an acute and potentially fatal allergic response that results from the release of various inflammatory mediators. But it's really, where is that cutoff? Where does it go, migrate from the territory of allergic reaction to anaphylaxis? And there's disagreement based on that. But what we do know is, as far as how anaphylaxis is defined, it is an acute, potentially fatal allergic response. And so it has to be pretty significant. But the result of all of this is that the true incidence of anaphylaxis is really unknown because of the discrepancies and professional disagreement on what anaphylaxis is, where it becomes anaphylaxis. The lifetime prevalence has been estimated to be about 1 to 2%, and we estimate that about 150,000 cases are seen in the United States per year. The cause, again, here it's very difficult to pin down. I based this on 2 studies, one out of the Mayo and one from Memphis. So about 33 to 34% are due to food, 13.7 to 20% are due to medications. There's a variety of medications that can cause it. Most commonly, it's going to be penicillins and cephalosporins, antibiotics, also sulfonamides, NSAIDs. And then 18.5% are due to insect stings. 7% is due to exercise. I'll talk about how exercise can cause anaphylaxis in a little bit. And then 25 to 59% are idiopathic. So that's kind of a wide range, but that's the range that I found in these 2 studies. So this is just an approximation, really. There's no known geographic variants. However, we do know that atopic diseases tend to be more prevalent in industrialized nations and are becoming more prevalent. So that may give some indication as to it might be more common in industrialized nations, but what I found, the studies that I found, they said that there's no known geographic variants. But intuition would lead you to think that, well, if atopic diseases are more common in industrialized nations and anaphylaxis tends to follow with atopic diseases, then it's probably the case that there is going to be more cases in industrialized countries. Now, while there is no known geographic variance, the causes are going to vary based on where you're at. So in tropical areas, you're more likely to have anaphylaxis from insect stings as well as from various plants, and that's just due to the increased biodiversity in more tropical areas. The highest frequency of epinephrine prescription are among boys 12 to 17 months of age. They make up about 5.5% of all of the epinephrine prescriptions. So even just based on that, you know that it's a pretty wide range. So that's not really saying too much. Severe food allergy is more common in children than in adults. We know that food allergies, a lot of them go away with time, particularly milk and egg allergies. However, the most significantly implicated allergies, food allergies that cause anaphylactic reactions, are typically peanuts, and that does not go away with time. About 90% of peanut allergies will persist into adulthood and beyond. Also, same with allergy to fish and shellfish. So the more severe food allergies, they tend to stick around with the patient. And so that's probably why we see these more commonly in children than in adults. Now, on the other hand, anaphylaxis to insect venom, anesthetics, and radio contrast media is more common in adults than children. Why that is, we don't really know. Probably because of repeat exposure. So you have to, in order to be allergic to insect venom, so let's say a bee stings you, you have to be exposed at least once. So you have to be exposed to a bee sting, and then it's the second time or third time you get stung by a bee. At that point, then you will have an anaphylactic reaction. So that's probably why some of these are more common in adults, because you have to have had it once before in order to get it, in order to get the anaphylactic reaction. You have to be exposed before you can have that IgE-mediated reaction where you're getting histamine release and leukotriene release and all of that. Okay. So, like I said, anaphylaxis is an acute, life-threatening, IgE-mediated allergic response. It most commonly manifests with cutaneous and respiratory symptoms. Now, there are all sorts of different symptoms. You can have GI symptoms, you can have neurologic symptoms, you can have cardiovascular symptoms, but it's the cutaneous and respiratory symptoms that will predominate. For reasons that are unknown, children tend to have respiratory symptoms before cutaneous symptoms. So like in this child that we saw, he manifested with wheezing and then loss of consciousness, which was probably due to either the low blood pressure or the fact that he wasn't getting enough oxygen. The cutaneous symptoms had not manifested yet. However, if it had not been a super severe reaction, the cutaneous symptoms would manifest. Now in this case, this child was so ill that if he had not came in, he probably would have died before the cutaneous symptoms had manifested. Now that's not a rule. So cutaneous symptoms can happen before respiratory symptoms in children, but overall, children tend to have respiratory manifestations before cutaneous manifestations. What I think, and I wasn't able to find this in any of the literature, but what I think is a reason behind this is that children have narrower respiratory tracts. So, what's the mechanism behind the cause of their respiratory symptoms? It's edema and bronchospasm. And remember, going back to respiratory mechanics, Poiseuille's law, that the resistance is going to be inversely proportional to the radius to the fourth power. What that means is that children, because they have smaller respiratory tracts, they're going to be less able to deal with any kind of obstruction or bronchospasm. And so for that reason, because they have smaller respiratory tracts, they are much more likely to be affected by any kind of manifestation that occludes their respiratory tract. And that's an overall rule for any kind of respiratory illness. Children tend to be more affected than adults. And so that's why I believe that children will manifest with their respiratory symptoms before their cutaneous symptoms. Whereas with adults, because adults have larger respiratory tracts, the same amount of edema and bronchospasm is not going to affect them to as great a degree, because remember that resistance is inversely proportional to the radius to the fourth power. And since adults have larger radiuses, they tend to do a little bit better even with some bronchospasm or edema. So with adults, they tend to manifest their cutaneous symptoms before respiratory symptoms, okay? Inflammatory mediators will increase the systemic vascular permeability, so things like bradykinin, kallikrein, histamine, prostaglandin 2, D2, those are mediators that are going to increase the systemic vascular permeability, and for that reason, we get a shift of vascular volume into the extravascular space, and that can be as much as 35% of the vascular volume in as little as 10 minutes. So that's pretty significant. Doesn't give the body much time to adjust, and it can result in hypotension. And we saw that in this child, and we can see this in anaphylaxis. And that's where we get the anaphylactic shock, because you're getting volume into the extravascular space out of the vasculature, and so you get hypotension from that. In addition, these inflammatory mediators, they also cause smooth muscle contraction, as we know, and so that comes from bradykinin. It's the basophils, they actually release kallikrein, and then kallikrein metabolizes the production of bradykinin. Histamine is one of the main mediators. That also stimulates vasodilation. It increases the vascular permeability and also directly increases the heart rate. So we do get tachycardia, and I suppose we would get tachycardia just as a reflex from having a lower vascular volume. Prostaglandin D2 is a bronchoconstrictor as well. It's also a pulmonary and coronary vasoconstrictor, and so as a result of this, we can get you can actually get myocardial ischemia. Okay, so that brings us to our culprits here. Foods are the most common cause of anaphylaxis. Peanuts are going to be the most common among foods. So peanuts, tree nuts, milk, eggs, fish, shellfish, fruits, and grains. And I do believe that that is going in order of their risk of causing anaphylaxis. So we do see peanuts much more commonly causing anaphylaxis than fruits and grains. Fruits are more likely to cause that oral allergy syndrome where you get pruritus of the lips, tingling of the lips, maybe some swelling of the tongue and oral mucosa. Drugs. There are a lot of drugs that can cause anaphylaxis, and this is really just some of them, the more common ones, but we see those antibiotics, penicillin, cephalosporins, sulfonamides, NSAIDs can be a cause, opiates can be a cause. My mother is allergic to morphine. When I had my appendicitis a few years ago, I was super concerned that I was going to be allergic to the morphine that they were giving me because my mom is allergic to morphine. But I wasn't, and the morphine did feel really good, by the way. It was the first time I ever got morphine, and at that point I did realize why patients get addicted to it. Okay, other things. So I'm not sure exactly why thiamine and vitamin B12 cause anaphylaxis, considering that we get this in all sorts of different foods. What I think that this literature had been referring to was as a supplementation. And then chemotherapeutics can cause anaphylaxis, and so the ones that are typically implicated are asparaginase, cyclosporine, methotrexate, vincristine, 5-fluorouracil. Insect venom, here we're talking about the genus, I believe, Hymenoptera, and that includes things such as bees, yellow jackets, wasps, hornets, and fire ants. So they're not, when you think of a bee sting, you're not thinking of venom, but they do have venom. They do have an antigen that does get into your skin and ultimately into your circulation, and that causes the reaction. Latex, so remember that latex allergies are correlated with allergies to raw fruits and vegetables. Allergen immunotherapy, well, we prefer that when these patients get their allergen immunotherapy that we're watching them, and we do indeed need to watch them for anaphylaxis. Exercise. Why does exercise cause anaphylaxis? And it can, and it does in many cases. The reason is because you can eat certain foods, and it can cause a small IgE-mediated response, enough to where you have your mast cells and basophils where they're about to degranulate, but they haven't degranulated yet. If you start to exercise, that's going to then be enough stimulation to where those cells will then degranulate. So that's what the thought is. You have a reaction from food or from something, medication, and it doesn't cause it does cause a response, but it doesn't cause a significant amount of degranulation to where you get symptoms. Then you go and exercise does cause some degranulation, but in a normal person, it doesn't cause enough degranulation to cause symptoms. But you combine those two together, and you get anaphylaxis from exercise. Anaphylaxis from exercise, it can happen in patients that aren't allergic to certain foods, but as far as why that happens in certain people and not in others, I'm not sure. Vaccinations, I believe this is because there are egg white components in various vaccines. Tetanus, measles, mumps, and influenza vaccines are the most commonly implicated. And then various other things. Radio contrast media is the one I want you to be most aware of because this is a common iatrogenic cause of anaphylaxis. What are the clinical manifestations? Well, we already saw hypotension is one, and that's why we call it anaphylactic shock in those cases. You can also get tachycardia. That's the most common way that this would show up. If you have a disturbance in your heart rate, it's usually tachycardia, and that's not only a response to the histamine, but it's also a natural response to the fact that you have hypotension or decreased blood pressure. However, you can get bradycardia in some cases. Hypoxia will result from the respiratory distress. The cutaneous manifestations you want to be well aware of because 90% of anaphylactic patients will have cutaneous symptoms at some point. So urticaria, those are your wheals, they're itchy, they're a little erythematous, they're raised, usually circular or ovoid in shape. Angioedema is swelling of the, well, it can be swelling in a lot of different places, but typically when we see it, it's swelling of the lips, the face, the tongue, the oral mucosa, swelling of the digits. You get flushing, that's due to the fact that you have vasodilation, peripheral vasodilation, and then pruritus just comes with the urticaria, and that's due to release of histamine, which causes the itchiness. Head, eyes, ears, nose, throat. You get perioral pruritus, conjunctival injection, periocular pruritus, rhinorrhea, nasal congestion, a sensation of tightness in the throat. That's just due to the smooth muscle contraction. It can also be due to laryngeal edema, and then sneezing. And then I would add that if you're looking at the head, you may see angioedema. Respiratory manifestations, important here also because these respiratory manifestations are severe. They can cause death. Dyspnea, wheezing, coughing, hoarseness, laryngeal edema. So we saw the dyspnea and wheezing in this child. Cardiovascular manifestations include palpitations, dysrhythmia, myocardial ischemia. Why myocardial ischemia? Because some of those inflammatory mediators can cause vasoconstriction of the coronary vasculature. That myocardial ischemia can cause chest pain. However, the chest pain can also be due to bronchoconstriction as well. Abdominal symptoms. This is another important one because in some cases, particularly when the allergen is ingested, so food allergens, abdominal pain can be the first symptom. So you get abdominal pain as just a manifestation of the allergy. That abdominal pain, if it's severe enough, can cause nausea and vomiting, and then cramping. That's really just a description of the abdominal pain. Important to keep in mind that abdominal pain is also a manifestation of hereditary angioedema, which is something that we need to differentiate out when we have anaphylaxis. We'll talk about that in a little bit. Genitourinary manifestations. Yes, allergy, anaphylaxis can cause uterine contractions, and typically that's going to be manifested as a low back pain. Neurologic, really, this doesn't come up too much. However, acute loss of consciousness can be considered a neurologic symptom. That typically happens, though, due to the low blood pressure or due to hypoxia. And then psychiatric manifestations, panic is a sign. often described as fear of impending doom. So these are your signs of anaphylaxis, but do remember these red ones if you don't remember any of the other ones. So for diagnosis, as a clinical diagnosis, you need to keep a high index of suspicion. Anaphylaxis is likely if any one of the following three criteria is satisfied. Now, these are criteria that I found in the literature, but as far as if you're looking at a patient with anaphylaxis, you really just need to get this down to where you see a patient who is flushed, low blood pressure, wheezing. You should really be thinking anaphylaxis just with that. However, this is evidence-based criteria. If you want, you can commit to memory, but for the test and for practice, you should have just a general idea of what anaphylaxis is so that when you see it, you know, I need to give this patient epinephrine. There are no contraindications to epinephrine. Yes, there are side effects, there are adverse effects and all that, but you don't want to waste time because the chance of dying from anaphylaxis is directly proportional to the delay in treatment, the delay particularly in providing epinephrine. So you don't want to just be standing there with your notepad writing down all the symptoms. You need to act quickly. So let's see. So I'm not gonna list all these, but you can write them down if you want. Really, we're just if you look at them, criteria A, it's having a reaction that involves the skin plus either respiratory symptoms or hypotension. Criteria B is either having 2 of 4 very commonly recognized anaphylactic manifestations, so manifestations of the skin, which could be things like urticaria or flushing, respiratory compromise, which would be things like wheezing or hypoxia, hypotension, and persistent GI symptoms. So you just need to have 2 of those 4. Criteria C is just hypotension in, after exposure to a known allergen. So a known allergen, I believe, for that patient. But hypotension after exposure to a known allergen. And then hypotension is defined here. All right, so our differential. This is where understanding those symptoms and the constellation of those symptoms is going to be important. So remember I told you at the very beginning that one of the things that are in our main differential are other forms of shock. So a patient comes in with a low blood pressure, very low blood pressure, we're concerned about shock. And so, especially when we have a child, we're not as much worried about cardiogenic shock. That's usually something that we see more in old people. But if it's a child with a history of heart defect or something like that, then yes, cardiogenic shock is a possibility. Septic shock is the one we're most concerned about. But like I said, it's very easy to differentiate this if you know that with anaphylaxis, there's a tendency towards flushing, whereas with these other forms of shock, they're going to be pale. Okay, so that should help you. Also, the history is going to help you too. So if there's a history of dehydration, obviously you're thinking hypovolemic shock. If there's a history of infection, you're thinking septic shock. Vasopressor reactions, that includes things like carcinoid syndrome. So in this case, you have flushing, you can have wheezing, you can have loss of consciousness, you can have low blood pressure, but typically carcinoid syndrome affects older people, 50, 60, 70, 80 years of age. And then also carcinoid syndrome will often have a history of diarrhea. Excess histamine syndromes, this can include things like leukemia. With leukemia, you can get a proliferation of cell lines that will produce and release histamine. We're not really thinking that in this patient because there is no history of leukemia and there's really nothing else to push us in that direction, but it is a possibility. MSG ingestion. This one's somewhat controversial. MSG is found in a lot of Chinese foods, canned vegetables, canned soups. It's a preservative. It's also a flavor enhancer. But to what degree this causes anaphylaxis, we don't really know. But we do know that it can cause things like flushing and wheezing and headache. So this one's controversial. MSG is generally regarded as safe, but idiosyncratic reactions to all sorts of different foods are well known, so I do include it here. Scombroid toxicity is a toxicity due to some kinds of fish, particularly mackerel or tuna, especially if they are spoiled. So that's a possibility as well, and that causes many of the same reactions that we see in allergic responses. Hereditary angioedema, with that, this is an autosomal dominant disorder. Abdominal pain features very predominantly in hereditary angioedema. Typically, this is described as a colicky abdominal pain, comes and goes, pretty severe when it happens, to the point where a lot of times this can get misdiagnosed as acute abdomen. There's also, with hereditary angioedema, there's swelling of the lips, face, and tongue. They won't have the wheals, the urticaria, but they will have the angioedema of the lips and face and fingers. Usually with hereditary angioedema, there is a trigger. However, in a lot of cases, it will be idiopathic. The patient doesn't remember what the trigger is, but when there is a trigger, it's typically trauma, surgery, which includes dental work, also menstruation, and illness can be a trigger. Any kind of stressor can trigger a hereditary angioedema episode, and I do an entire lecture on hereditary angioedema, so you can look back at that. Panic attack typically is just that impending fear of doom. It can cause increased heart rate, it can cause increased respiratory rate, however, it will not cause hypotension, and it won't cause any of the, it won't cause wheezing typically, and it won't cause, I suppose if the patient has asthma, then a panic attack may trigger an asthma episode, but that's really getting into more complicated cases. So panic attack is typically just going to be the increased heart rate, increased respiratory rate, and generally goes away. The patient often has a history of panic attacks. If you get a history, most of the time these patients are going to be awake and they'll be able to at least talk to you. They're also pretty short-lived too. So these patients typically don't call an ambulance, although you never can rule that out. Vocal cord dysfunction, that is of course not going to manifest any skin symptoms. The heart rate usually is not high. It's just going to be difficulty breathing. Usually with vocal cord dysfunction, it's going to be more stridor. It's going to be more difficulty with inhaling, whereas asthma is going to be more difficulty with exhaling. Pheochromocytoma, you can get increased heart rate, increased respiratory rate, you can get flushing, you can get acute loss of consciousness, you can get anxiety, but with pheochromocytoma, the thing that's important that helps you differentiate it from anaphylaxis is that you have an increased blood pressure, not a decreased blood pressure. Red man syndrome, this is something that causes flushing, and it's also associated with the medication, particularly a medication that is associated with anaphylactic reactions. However, with red man syndrome, it's just that. It's just flushing. Globus hystericus can manifest as a sensation of fullness in the throat. Typically, this is in patients who have GERD. So I just included that there for completion's sake. So you can see that these various diagnoses can be associated with symptoms that we do see in anaphylaxis. If you have an acute onset of severe bronchospasm in previously well patients, you should always consider anaphylaxis. Asthma would really be the only other thing that we would be thinking of, at least acutely, and typically those patients will have had a history of asthma. Any kind of sudden loss of consciousness in the absence of cutaneous symptoms should raise suspicion for possibly a vasovagal collapse. Or you could consider in older patients things like MI, pulmonary embolism, even seizures as a possibility. Laryngeal edema plus abdominal pain, as we mentioned, that always is going to suggest a hereditary angioedema. Okay? So I know I didn't talk about these all in great detail, but I do talk about these in other sections. So what do we do for management? So with managing anaphylaxis, we hope that these patients have their EpiPens, and we prescribe EpiPens, which is just epinephrine auto-injectors, We prescribe it to all patients who have severe allergic reactions or with risk factors to severe allergic reactions. So if we know that they have a peanut allergy, we know that they're allergic to bee stings, we want to make sure that they have EpiPens. Now the problem is chicken and egg, right? If you have to have had a severe allergic reaction for us to know you have a severe allergic reaction or a predisposition to severe allergic reaction. So at some point, these patients are going to come in for the first time, never having been diagnosed before, like we saw in this patient. So not all the time are we going to know that they have anaphylaxis and they're going to have their EpiPen. However, with subsequent cases, you can have patients that come in with a known history and they just didn't happen to have their EpiPen available. Also, anytime a patient, I'll get into this, but anytime a patient has a reaction to where they need their EpiPen, they should be coming into the emergency department anyway. So epinephrine is the cornerstone of treatment in anaphylaxis. That's typically given intramuscularly. However, there are reserved cases in which you will give it intravenously if there's severe hypotension. The Trendelenburg position is advisable. Okay, so this is something you want to tell parents. It has been shown in some studies that the positioning of a patient actually relates to their survival. So the Trendelenburg position, you just want to make sure that the patient's legs are elevated. So their legs are elevated, I think it's like 10 degrees above their head. So that's pretty much all it is in the field. And by field, I just mean before EMS arrives. So their epinephrine. There are cases, if it's not severe enough, if there's not pulmonary or cardiovascular symptoms, if it's just limited to one area, so if it's like just skin symptoms, if they just have urticaria, then in that case they can have antihistamines and they don't necessarily need epinephrine. However, if there are severe symptoms or if it's ever respiratory distress or fainting, they need their EpiPen. Okay, when they get to the hospital or when they're on their way to the hospital, the most important thing that you do first, even before epinephrine, is that you ensure that they have an adequate airway, that you provide oxygen via face mask, and that you establish venous access. Because remember, even before you give medications, you always want to make sure you're doing everything you can to make sure the patient's stable. That having been said, in practice, you're sort of doing these things kind of at the same time. So you may have a nurse doing the venous access and getting the oxygen in while you are assessing the patient for anaphylaxis and ordering the epinephrine ASAP. Epinephrine should be given intramuscularly if it hasn't been provided yet. If it has been provided and it was more than 10 to 15 minutes ago and they're still not responding, they're still in respiratory distress, you can provide it again. You can provide epinephrine every 10 to 15 minutes until you get an adequate response. IV epinephrine is provided if there's severe hypotension. As far as the dosing for epinephrine, I wouldn't really worry about it. However, if you do want to know, it's 0.01 milligrams per kilogram up to 0.3 to 0.5 milligrams intramuscularly for children under the age of 12. For everybody else, it's going to be 0.3 to 0.5 milligrams intramuscularly. If it's given intravenously, it's going to be 0.01 mils per kg per dose, but we give a different formulation, a more dilute formulation of epinephrine. So it's not the same epinephrine you give intramuscularly. Just as a tip, if you cannot establish venous access in a patient that you want to give IV epinephrine to, you can actually give the intramuscular epinephrine below, I believe it's below the jaw, the sublingual space. Okay, fluid resuscitation. This is important, especially if the patient is hypotensive, as this patient was. So we just give a bolus, and we just continue giving fluids, titrating it to blood pressure. So the rule for fluid resuscitation in children is it's 20 mils per kg, normal saline. For adults, it's 1 liter normal saline. And you just continue providing that, titrating it to blood pressure. It's not at all uncommon to have to give 3, 4, 5 boluses of normal saline in adults. remember that you are extravasating up to 35% of the fluid in your vasculature, so it can be a significant amount that you have to provide. For significant dyspnea, you can give nebulized albuterol, and that can be just provided with their face mask. Okay, so once the patient is stabilized, and that typically should happen pretty quickly, then at that point you're going to give antihistamines and corticosteroids. Now, corticosteroids are not necessarily indicated. I don't believe they've been shown in any literature to necessarily confer any increased survival benefits, but antihistamines all the time. But most physicians will give both antihistamines and corticosteroids. Why are we giving antihistamines and corticosteroids after they're stabilized? You think, well, we have stabilized the patient, and we can now observe them and then send them home. We give antihistamines and corticosteroids for a very good reason, and that is because with anaphylaxis, what you can have, and what you often do have, is a biphasic reaction. So in other words, you get an immediate reaction within 2 hours of exposure to the antigen, and then 3-4 hours later, you get another anaphylactic reaction. Okay, so 90% of biphasic reactions occur within 4 hours of the initial exposure. So this is why we provide antihistamines and corticosteroids, because it will prevent that second reaction. So this is also why we want to observe patients for at least 4 hours, no matter what. If we had to give them epinephrine, they need to be observed for at least 4 hours. This is also why patients who, let's say, they had their EpiPen, they were at school, they were exposed to something, they had their EpiPen, and they're okay now, they still need to go to the hospital. And they'll be observed for at least 4 hours after the exposure. But typically it's a little bit longer. Whether or not you want to admit them is going to be based on the severity of symptoms and any other complications. That's just going to be a judgment call. Preventative treatment. So we want to make sure that they are not leaving without an EpiPen, at least 2. So the EpiPen is just an auto-injector. It's pretty easy to teach the patients how to use them, but they do have little placebo EpiPens that you can teach them how to use it, and they can demonstrate to you that they know how to use it, so you're not sending them off worrying if they know how to use their EpiPen. You want to send them home with an antihistamine orally, so cetirizine or loratadine, and then corticosteroids, get prednisone, 1 mg per kg up to 75 milligrams. So the antihistamines and corticosteroids will be taken for 3 days following the anaphylactic reaction. You want to have an allergy action plan. That's just a piece of paper that shows what they're allergic to. A lot of times you won't be able to work this up in the ED, but they should be seeing their primary care physician. They'll try to figure out what they're allergic to if they can, and that's what will be on the allergy action plan. It's really just a piece of paper that's given to school officials, to a coach, to a babysitter, so that they know what to do in an emergency. Like I said, they should follow up with their primary and within 1 week to get an idea of what the possible cause was for all of this. Consultation with an allergist can be really helpful for doing further testing like RAST, and you can get antibodies and stuff like that. Patient education is very important. You want to give them instruction on how to avoid these various allergens that you think may be behind it, ideas of what the early symptoms are, although it's usually ingrained in the parent's head when they have to deal with their children having a reaction like this, but early symptoms, things like wheezing or rash. Then also stress the importance of early treatment. So as soon as you think there are symptoms of anaphylaxis, you're giving the EpiPen. And a medical alert bracelet is not out of place. I'm a big proponent of medical alert bracelets because if you lose consciousness, the people are not going to know what's wrong with you. EMT is not going to know what's wrong with you. And so a medical alert bracelet can be really helpful. What are the complications from anaphylaxis? Well, what I really want to point out here are some of the things that can complicate your treatment, because obviously the big complication of anaphylaxis is death. But as you're treating patients, if some of these patients, if they're hypotensive, especially adults that are on beta blockers for like post-MI or for high blood pressure or reasons like that. If they're on beta blockers, they may not respond adequately to epinephrine, because remember, when you're giving epinephrine, the primary thing you're doing with that is bronchodilation to counteract the bronchoconstriction. And that is all beta mediated. And so if they're on beta blockers and you're giving epinephrine, those two are working against each other. And so you may have difficulty with both with your blood pressure and with your respiratory distress giving epinephrine. Usually the bronchoconstriction will be a little bit easier to manage than the blood pressure. So in these cases, these patients that are on beta blockers, they can be hypotensive, and you give the epinephrine even intravenously, and their hypotension is refractory. And in these cases, you can provide atropine, especially if there's bradycardia. A lot of physicians will prescribe glucagon. That is okay for refractory hypotension, but I will just warn you that it's not FDA approved for that purpose. Of course, the biphasic reaction is a big complication, and we are really concerned here with any patient possibly having a biphasic reaction. It's for that reason, like we already talked about, that you're going to be giving the patient antihistamines and corticosteroids. In cases where the exposure to the antigen is unavoidable, so there are some cases, things like food allergies, typically we can avoid them if we try hard enough, but there are some things where we really can't avoid the allergen. So, for instance, bee stings. We can't avoid that. You're outside in the summer, you're not going to tell a kid that you can never go outside because you're worried about a bee sting. So for those cases, for things like bee stings, we can do immunotherapy. That's recommended for insect venom prophylaxis, 97% effective at preventing recurrent reactions. With things like medications, sometimes we can't avoid certain medications, like antibiotics sometimes. So what we prefer to do is provide oral agents instead of IV if we can. And the reason for that is pretty obvious. If you're giving something intravenously, you're giving a large load of it at a single time, and that's going to trigger a much more severe reaction than if you give it orally. If you're giving it orally, it's usually absorbed a little bit slower. We can also do in patients where we need to give medications that we know they're allergic to, you can either do desensitization or you can provide pre-treatment with corticosteroids and antihistamines. So an example here would be a patient that requires radio contrast for some kind of urgent imaging. What you can do is you can provide them prednisone, which they would take 13, 7, and 1 hours prior to the administration of the radio contrast, and then provide a antihistamine prior to the administration of radio contrast. And doing the two of those together dramatically reduces the risk of having a reaction. So there are various things that you can do if exposure to the antigen is unavoidable. As far as prognosis, up to 500 to 1,000 cases of fatal anaphylaxis occur annually in the United States. And most commonly, the cause of death is going to be circulatory collapse, hypotension, or respiratory compromise. The estimated mortality of a given anaphylactic episode ranges from 0.65 to 2%. Mortality is going to be related to both whether or not they get to the hospital, because we want to prevent a biphasic reaction. It's going to be related to, I think it's going to be there is a relation to age, but I'm not sure on that one. But there is definitely, and this is the most important one to know, there's a linear relation between how long it was until you got your epinephrine and the mortality. So the longer it takes to get your epinephrine, the more likely you are to die from anaphylaxis. Oh, and then another thing that correlates with this is just one study that I saw, and this was out of the UK. Foods and insect stings account for a quarter of the fatal episodes, so that's significant. Half of them are iatrogenic in origin, but those patients are already in the hospital. So when you're seeing a patient presenting, it's going to be food and insect stings that are going to account for the majority of fatal episodes. And I already said delayed administration of treatment and asthma are risk factors for fatal anaphylaxis. So that's delayed administration of epinephrine. And then asthma are risk factors for fatal anaphylaxis. As far as why asthma, not exactly sure. Possibly the fact that they already have hyperreactive airways, but I'm not exactly sure there. Exposure avoidance and patient education are paramount to outpatient management. All patients should carry an EpiPen with them at all times. So if they've ever had an anaphylactic reaction, they should always have EpiPens, and they should always carry that EpiPen, usually two EpiPens, but they should always carry it with them at all times. So tell a woman, keep it in your purse. Tell mom, keep it in your purse. Kids should have one at school that's readily available at the nurse's office. As they get older, they should carry it with them on their person. And there's actually been a study that has shown that only about 6 out of 10 patients who should be carrying an EpiPen with them at all times actually do carry it with them. And I believe that was the study was just having allergists ask the patient, do you have your EpiPen with you right now? And actually only 6 out of 10 indeed did have their EpiPen with them. So it's very important that you stress that, because if a patient has an allergy action plan, but they don't have their EpiPen and there isn't one available, it's not going to do much good. So they need to be carrying that with them at all times. Very important. So if you have any questions, go ahead and write me a note below, but hopefully I gave you a pretty good idea of how to work with this.